Hello, everyone. We're very glad that you're here for the third of 3 wonderful forums about how changes in federal funding are affecting the nation and Nelson County and the people who are living here. So, Brad Rein is a retired National Science Liaison for the U.S. Department of Agriculture's National Institute of Food and Agriculture, and he's going to be speaking on how changes in funding for SNAP, which is food stamps, basically, and food safety are likely to impact us at the state and local level. Agribility is a program that Brad implemented in 1991 to help farmers with disabilities continue to farm. And so Virginia has an Agribility grant and has helped farmers in our area. And then after Brad speaks, we'll have Dr. Wayne Hachey. He's a member of the Wintergreen Rescue Squad and will speak on a paramedic program for which he obtained funding. And that program arranges referrals for clergy and EMTs to do home visits for follow-up with people discharged from hospitals. And those follow-up services include safety checks, needs assessments, medication assistance, and transportation arrangements. And Dr. Hachey also serves on the board of directors for Blue Ridge Medical Center. And finally, winding up our program with our speakers tonight is Michael Cook. He's a partner and co-chair of Lyles Parker Healthcare Group. He practices healthcare law and was an attorney at the Federal Department of Health and Human Services overseeing regulations for Medicaid. And Michael is a former co-chair of the Virginia DMAS, or Department of Medical Assistance Services Board, and currently serves on the board at Blue Ridge Medical Center.
First of all, I'd like to thank all of you for coming. This is going to be a relatively short, just pick up on some of the highlights. I've been asked to talk about the SNAP program, food safety, and as you mentioned, Agribility was a program I started over 30-some years ago. One of the things, what I want to do is I want to try and keep it as basically brief as I can, really focusing on the things at the national level that also really impact you specifically at the county level with Nelson County, and bring all of that together. The food safety program is again, SNAP is administered by the Food Nutrition Service of the USDA. It's not a program in NIFA, but I am aware of some of the things we do to support it, as well as the food safety. We do a lot of things with the National Institute of Food and Agriculture that support food safety. Just to give you some idea, NIFA is the agency that supports extension, research, and education. So it supports the extension programs in the land-grant universities. So things like NIFA was I was providing some oversight for 4-H, the Master Gardeners, things that you might be more familiar with. Those are all part of, we're all part of that system. And we've always worked very collaboratively with the land-grant systems. It's more of a soft sell most of the time, what we would do, except for the competitive grant programs, which the competitive grant programs are basically, that are managed by the NIFA, but we also do peer review. So basically the people who review those programs are the same scientists that actually do that work. They just cannot have a conflict of interest when they're reviewing proposals. We also provide the capacity funds for these universities. I'm going to talk about some of those as they relate to these topic areas. And so I guess maybe I'll just get started with the SNAP program. Give me the next slide. So there's a lot of information here on some of the Supplemental Nutrition Assistance Program, which is what the full name is. And this slide basically just talks about some of the changes for recipients under the bill, the beautiful bill, I guess is what it's called. So one of the things they're changing the maximum age that you're required to work from 54 to 64, and that's basically working a minimum of 80 hours per month. And how they divide that out is up to the individuals and what they can do. It includes adults with children 14 to 17 years old. It used to exclude them up to 18. It also removes exemptions for things like homelessness individuals, veterans, those people younger who aged out of the foster care system. So it has increased the number of people or reduced the number of people that are exempt from the requirements. It also prohibits inclusion of certain types of internet costs, some of the household allowances and shelter costs, and it also identifies utility allowances based on the recipient and energy assistance in terms of looking at their costs versus their income. The second part of the changes in the SNAP program had to do with cost sharing, and that's probably gotten a lot of attention. Everything I'm talking about, there's a handout in the back, and I'd encourage you to get it. I'm going to try to stick to the basic information, but if you want to, there's a lot of websites out there that you can reach down and get a little deeper dive into what the information is, and those handouts are in the back, I think, where you came in. So. One of the changes is that they want to lower the error rate. Error rate is actually an error of either being overpaying someone as well as underpaying someone. So it's a combination of both. And the error rate is basically it has to do with what the allotments are going to be and whether there's going to be a matching contribution required, or that the costs are going to have to be incurred by the state rather than the federal government. So starting in 2028, the states with payment error rates above 6% must contribute 5% to 15% of their benefit costs. In Virginia, that amounts to, I think, roughly about as much as it could be as if we didn't lower their error rate, which is currently at 11.69%, somewhere down around 6%. It's going to cost like $250 million of Virginia taxpayer dollars to basically come up with the amount of money that would cover the costs that would be eligible under the SNAP program. It also reduces the amount that USDA will pay states for administering. Currently, the state pays 50% administrative costs, federal government pays 50%, and it's going to drop it to 25% for the federal government and 75% for the states. I think so. That's pretty much the cost sharing. One of the other things to take in consideration is that not only is it going to have an impact on the people receiving the SNAP benefits, it's also going to have an impact on the small, particularly small food vendors, food retailers that provide accept SNAP food, I guess they call them food stamps. The way it does that is, if you think about it, larger retailers like Walmart, others like that, they can absorb those costs a lot easier because they have a lot higher profit margin. Small independent retailers have a profit margin of somewhere between 1% and 3% typically. If they lose customers, that has an impact on their business and while their business will continue. So that's one of the things we have to consider. It could be we could possibly lose some of our food retailers. So this over here is just in Nelson County. To give you an example, we have a population of 14,692, roughly. 1,755 are on SNAP program. Is that from recipients? That's about 11.9% of the population in Nelson County. And there are 13 retailers in Nelson County that accept food stamps. So that gives you some idea what that looks like on a county level. You can go to the next slide. Now, one of the things that is on the handout is actually kind of, if you're really interested in how Nelson County may compare with other counties in the state or across the country, this is an active map, an interactive map. if you move your mouse around, you can pull up any county you want in the entire country and see how they differ. Maybe you're interested in, would like to know how that's impacting a county where maybe some of your friends or your relatives live. So that's something that's there and that is available. So I found that, I just thought that'd be interesting to bring it to your attention if you have an interest in that type of thing. And the darker it is, the more people, or a higher percentage are on the food assistance programs. And some of these locations, if you look at it, a lot of that is relevant to Native Americans, things like that, that may be in a situation where they just don't have that work available. There is one, the work requirement, by the way, it will probably not impact Nelson County, but counties that have what do you want to call it, job opening rate above 10%. Basically would not be able to, can basically get waived. In other words, if they're coming up the wrong word here. Anyway, their unemployment rate is above 10%. They may be able to waive the work requirements. So things like that are in the bill. The other thing I wanted to mention is there are Governor Youngkin has put out an executive order on the SNAP program and how to bring that rate down to around 6% by 2028. So we don't have, so Virginia taxpayers do not have to incur those types of costs, that extra $250 million, I guess it is. So that's one of the problems, one of the things that executive order is supposed to address. And he's going to do that through things such as some additional training for the people who make the decisions on if someone's eligible or not, provide some other methods that they might be able to find error rates. Right now, a lot of the decisions about who's a SNAP recipient are based upon the information from the person applying for the SNAP program. And it's just their verbal for great information on what their income and some of those things are. There's going to be methods in the place to try and check some of those things and see what their eligibility is. And it'll lower the error rate. And they're also looking at some technologies that might be used to help make those decisions a little easier. Because one of the reasons states have had high error rates is because there were times they might get a lot of applicants in and they would make a decision. For them, it's more important to make sure that people who need the food are getting the food. So they will put the priority on processing them and not look at the people who are currently getting the stamps and take that error rate and basically accept that as, because to them it's really this is basically a hunger program. You want to make sure nobody goes hungry. So that's the whole point of why some of these states have had higher error rates than others. Let's go to the next topic. This one's a little more food safety. There's any type of program that has to do with safety. It kind of has three pillars that support how well it can work. And those three pillars tend to be education, enforcement, and engineering. And I have a long history in working in agricultural safety and health. And that's one of the things I learned early in my career, is that you need all three for the things to work well. The education is important in terms of making sure people know what the safe practices are, or in this case, how to cook and keep food and basically store food safely. So there are programs out there to do that. One of those through NIFA, and it's a capacity program, and it funds Virginia Tech, and it funds the Virginia State University Extension Services. And what it does is it provides a program for funding a program called Expanded Food Nutrition Education Program, EFNIP. And that program is in Virginia. Those two universities collectively get about $2 million a year to run that expanded food nutrition program. What that does is, and it's been very, very, very successful. It has the people who participate in it report about 70-80% of them say have indicated they have improved their food preparations to make it safer, or their food storage to make it safer, and it's having a good effect on that. The sad part is looking at the 2026 budget, which is the one which should have started at the beginning of October, and that program has been removed. So that's a $2 million loss for those two universities, and basically eliminating a program that would provide that type of education to people who are interested in trying to learn how to make their food safer and store it and prepare it more safely. The enforcement for the food safety and nutrition comes from, again, looking at it's usually with Health and Human Services. Food Safety Inspection Service does that. As you know, we are currently in a shutdown for the federal government, and so they did not lay off the inspectors, but the reality is they are kind of compromised on what they can do because they don't have the support staff around them to do the things that they need to get done. It also will probably limit, and they've already indicated that they will be conducting fewer food safety inspections as a result of that. A lot of our food comes already prepared and prepackaged from other countries. So those inspectors would also travel those other countries to make sure that they were operating in safe practices, so that before the food got here, we didn't get into situations where you have a lot of food recall, things like that. And so that is one of the things we don't know what's going to happen, because it's basically, you basically don't know when you're going to have issues with food not being safe or not. And you've all seen different types of food recalls over the years. One of the things I would have to say, though, is that is most food preparation companies that prepare prepackaged food for shelves, they do not want to see, obviously they don't want their food recalled. That's not good for their business. Just give an example. Many years ago when I first started with USDA, we had executives from Herbert's baby food, and they were coming to us and they were very pleased to see we were making progress in removing basically pesticides, herbicides from the production aspects of food and going with natural foods, because they do not want to see anything happen with their baby food. As a matter of fact, they are so concerned about shelf space that they have enough food canned and ready to put and replace every inch of shelf space in every store across the country if they ever have a recall. That was something I never realized, that's how seriously the food industry really does take these things. The engineering, it's just a lot of different things. Obviously, you're going to try and engineer just like you have safer cars, but you have all sorts of things. You have safer processes for preparing food as well. Things that we would support food safety research through a number of different avenues, mostly competitive grant programs. Basically, that are things that are basically brought to our attention by our science community as well as the food industry itself. This is where I would like to see some additional research and education to help with these issues. Engineers designing out the issue, the problem is also you just look at how do you make it a safer environment. Then you don't have to depend on either enforcement or education, because we don't always follow the safest practices as individuals. So that's kind of where I want to stop with food safety. The last program, and I want to talk about, is the agribility program. This is the cover of the website for the Virginia Agribility Program. This program was started, again, it was authorized in the 1990 Farm Bill, first funded in 1991, and it was only the second committed program in what was then the Extension Service at USDA before we merged with the research side. And so I was asked to stand it up. And it basically, what it does is it funds, again, the land-grant universities, Virginia Tech. In this case, both Virginia Tech and Virginia State University work together, and they will also work together with Easter Seals. And what they do is they will, if anyone comes to them, well, they'll actually do a lot of their own marketing, but if anyone comes to them who has a disability in agriculture, wants to continue to work in agriculture, they will do an assessment, and they will see what they can do to make the workplace safer. Many times it's egress on agriculture equipment. Sometimes it's just other aspects of making the work site safer, and how they can get then funding to get those accommodations made. This program is also, it has a national project which does education for the state projects, because you're combining two different entities. So basically, the current grant recipients will come to those programs. We'll also bring farmers to those programs who have been helped by the program to give us advice and listen to how the program has helped them. This has always been my favorite program. I've overseen maybe 70% of the agency's total $2 billion budget over the years. But this one was the one that when you go out there and you hear these farmers talk about how the program has made a difference in their lives, and they get emotional. And you know you've got a program that's working when you have that kind of feedback. So that always gave me the momentum to go back and keep the money flowing. And this program, fortunately, I want to leave on a good note, is still funded. It's been moved, I don't know exactly where. I won't say if I did. The funding location from another source in the federal government, and much safer than where it was. It was on the same 3D line item that the expanded food and nutrition program was on, that has been cut from the budget.
A few reasons why I'm here talking about the community paramedicine program. First, I've been volunteering with Wintergreen Rescue for a little over 12 years now. I'm the county infectious disease officer. I wrote the grant for this, but the most important reason why I'm here is that the community paramedic who is supposed to be talking to you is covering over at the music festival. And I have to thank her because I've boldly stolen her slides with absolutely no remorse whatsoever. Next slide. So who are we? Well, Wintergreen Rescue Squad is a nonprofit organization that provides EMS services for, surprise, Wintergreen. But what most people don't realize is that the Wintergreen Rescue Squad is also contracted through Nelson County to provide EMS services. So the rescue squad that's right down the road is actually staffed and managed by Wintergreen Rescue. So when they're full, they have 2 ambulances. When they get that third call, 9 times out of 10, it's Wintergreen that's responding. And when we've got our 2 ambulances out, then they usually step in. Actually, they always step in. So when you see this Nelson EMS, look down at the door, and it says staffed by Wintergreen Rescue, just to prove that I'm not lying. So next slide. So who pays for this? This is all funded through a grant through Centera Cares, and they gave us the grant so we can provide the community paramedicine program for all of Nelson County. And in fact, most of the patients that we wind up seeing are from Nelson and not necessarily from Wintergreen. Wintergreen represents just onesies and twosies, whereas most of our patients are actually serving the county, and it's free to everyone. As long as you live in the county, it's a freebie. Sorry, next slide. You'll get your steps in today?
Yep.
So who are our community paramedics? So these are the same paramedics that go to your front door when you're having a heart attack. But they're not exactly the same in that they've also had specialized training to make home visits for these particular specialized skills. And next slide. Oh, you might as well just stay there. So what do our community paramedics do? And next slide. Okay. So a bunch of stuff. So one of the things are home safety inspections, fall prevention education, and we'll see later as far as our results for the program, where this has really had a significant impact on EMS calls for the county. Assessment of individual needs, so people with complex health conditions. Connections to both community services and primary care services. And then as far as education on chronic diseases, so you go to a doctor's office and he tells you, you got this. And then we're going to do this, and this for you. Do you have all that? Any questions? Good. Have a nice day. And what you heard is, you have this. So managing particularly chronic diseases becomes very difficult and very complex, and the service will help by coming into your home and explaining things to you for as long as it takes to get all your medications, so you know what you should be taking, when you should be taking them, how to best manage your disease. We also develop emergency action plans, and this is primarily for children with special needs. So kids with complex congenital heart disease, kids with at-home ventilators. So kids with really complex issues. When things go wrong, it's sometimes hard to kind of sort it all out. Who should I call first? What should I do? And the community paramedics will help with an action plan. And then probably the biggest thing is to act as a matchmaker between the people in need and what's out there in the community. Okay, next one. So the best way to, and you can just fill the slide. So the best way of describing exactly what we do is by some stories. And this is one story where Nelson County Social Services notified the community paramedics that there was an elderly couple had not eaten in 2 days and both were diabetics. So they went in and found that they didn't have any electricity, they didn't have any water, they didn't have any food or transportation. So they collaborated with the food pantry and got them food through emergency food box. They actually went to one of the local restaurants, got them a couple hot meals and brought it back to the home. They set up monthly deliveries of food boxes from the pantry. They collaborated with the local churches and the county's social services to get their electricity and water running again. They introduced them to a senior program in Livingston that has a number of benefits that would be to their advantage. They assisted in obtaining resources to make sure they had transportation to their next medical visit, and made sure that they had the resources to get their meds for their ongoing medical conditions. So within 24 hours, their power is back on through social services. They continued to work with the couple to make sure that all their essential services were both on and continued. Their immediate food and security issues were all addressed. They collaborated with JABA to arrange twice a week a trip down to the Nelson Heritage Center where they could get both a hot meal and additional services. So the next one is much simpler, but still had a significant impact. So this one was an EMS referral. So we were getting calls, sometimes multiple calls a day, for lifting assistance. So the community paramedics came in and they found that there was an elderly client who had a husband and an adult daughter. The elderly client had a debilitating neurological disease that confined her to a wheelchair. And she kept on falling out of the chair. And then EMS would be called and they'd go to the home and put her back in the chair. So in talking to the patient, they realized that the patient really had no control over her disease. The only control she had was whether she could wear a seatbelt or not. And she was not going to wear a seatbelt. So the community, am I hitting something? Okay. So the community paramedics spoke to her and said, well, gee, when you call 911 because you've fallen out of your chair, we can't respond to your neighbors if they have a real emergency. And sooner or later, when you fall from the chair, you're going to hurt yourself. And after that discussion, she agreed to use her seatbelt. They called a week later and confirmed that she was wearing her seatbelt every day. And since that initial visit, not one EMS call, tracking back for 4 months. So a little measure, a one-time visit with a significant improvement in their quality of life. Next one. I think it's got one more click. Yeah, okay. So this is just an example of, this is a fake patient here, but this is the kind of information that we would generate. So kids with special needs, one example would be, again, a child on a home ventilator or a child with complex medical conditions. What the community paramedic will do is come up with an emergency information form for the parents to use should something go awry. In addition to that, they'll contact the child's either primary care provider or specialty care provider to make sure we're not missing anything or anything that can be tweaked. So this is one patient had just a bunch of medications, and there was just in a pile. And because of this kind of disorganization, they weren't taking their medications. They couldn't keep track of what they should be taking and when. So they were missing a lot of meds. So what we did is we went and got all of their medications, and this is actually your paramedics down in the station right down the road, and they organized them, put them in a box so the patient can now know what they should be taking and when they should be taking them. So improving that patient's health by just helping them with compliance with the medication regime that they have. Another example is just working with our community partners. So a lot of people with new special needs have a need for durable medical goods, whether it be a hospital bed, toilet commodes, ramps, armrests, wheelchairs. So in working primarily in this area with All Blessings Flow, we're able to set up those durable medical goods in homes where patients need them, rather than having them go out and actually having to buy all this stuff. So what's been the impact of the past year? Well, there's been a 40% reduction in EMS calls for falls. And repeat EMS transports within 30 days was down by about 20% just over the past year since this program was started. So who can refer? Well, sometimes the referral comes when we go into a home and go, gee, they could really use the community paramedicine program. And then we'll ask the patient, would you mind if we enrolled you in this? There's no obligation, but they'll come to your home and talk about X, Y, or Z. Social workers, hospitals, community resource partners, school counselors, family, neighbors, medical offices, and last of all, you can refer yourself into the program. So, how does that happen? Excellent. So the first way, you can go to the Wintergreen Fire Rescue website, click on Community Paramedicine, and then click on Complete the Referral Form. So that's like 3 different steps. Easier than that, next slide. You can call the community paramedic cell phone. They won't answer this right away. It's not a 24/7, but they will take the message and get back to you. Or you can just email the community paramedicine program, or you can just scan this image. And if anybody needs information on how to do this, I've got about 20 copies for you to be able to scan the image to make a referral. So once we get a referral, the information is reviewed and a plan is starting to be developed. We then contact the patient by phone, say, do you want the service, just to make sure. And then there's a visit is scheduled. And the visit usually is 45 minutes to sometimes an hour and a half. And like all medical care, you got to sign the HIPAA form. So all of this is privileged information. And after the visit, you'll get a written summary of everything that was discussed, everything that was done. And if the issue is closed, we leave agreeing to exchange Christmas cards every year. If a phone call is needed after, then a phone call is scheduled. Or if repeat visits are needed, then those visits are also scheduled. So it's not necessarily a one and done kind of visit. If you need continual visits, then that can be arranged. So probably the most important part of this whole program are our community partnerships. And the community partnerships really make the program work, either by getting referrals into the program or us linking patients up with the resources that these partnerships avail us to. And these are just some of our partners. So social services, Region 10, home health agencies, churches, the Nelson Food Pantry or other food donation services, clinics and medical offices. All Blessings Flow is a fairly big partner, particularly with durable goods. Community clubs and programs, and the list kind of goes on, but these are our main players. So the one question that keeps on coming up, so if I need a dressing change or if I need a catheter change, do we use this service for that? And unfortunately, not yet. So right now our goal is to identify and assist patients in navigating the healthcare system, to link them with the resources that are in the community, and then give them the information they need and the resources they need to essentially stay out of the hospital and emergency services. That's okay. So we're applying for a couple more grants. One grant that we're currently applying for is just to continue the program as it is. Our next grant, ideally, we would be able to expand the program so we can go into the home and do like dressing changes and hopefully preventing a lot of bounce backs from hospital admissions. So again, this is our phone number, our email. And just to reinforce that cell phone is not manned 24/7, but we will get back to you. Usually it takes just a few days and you'll be getting the call. And I think that is it. Unless my short-term memory is failing me. Nope, okay, good.
Now we're ready for Michael Cook and he's giving us an update maybe on Medicaid.
On what's going on in the Medicaid program. Under the, basically called one big beautiful bill, or I'm going to refer to it as HR1, which is a short term on that. First of all, as Peggy mentioned, my name is Michael Cook. I've been practicing healthcare law for more than 50 years. 42 of those have been representing healthcare entities and practitioners and their associations, and substantial part of that work was helping them navigate the Medicaid program. I also started my career back in 73 through 80 representing the federal regulators of the Medicaid program, and for 8 years, ending in 2023. When I term limited out, I was on the board that oversees Virginia's Medicaid program, and the last 3 years, the 3 of those was as chair, and on the board of Blue Ridge Medical Center. As I mentioned, I'm going to be talking about the significant cuts that Congress made under the Medicaid program and under H.R. 1, and hopefully how they affect you in the community, and perhaps even just some of the things to be on the lookout for if you are on Medicaid or if you are on the exchange. H.R. 1 covered a variety of topics, including the extension of tax cuts that were first enacted under the first Trump administration, additional tax cuts, additional funding of defense and immigration enforcement, and a wide range of program cuts, including provisions that will result in major cuts to safety net programs, including Medicaid and SNAP food stamps, as Brad has mentioned, programs and the exchange, and in order to partially pay for the tax cuts. In the bill, H.R. 1 was enacted, and in the Senate under a process in July, and in the Senate under a process referred to as reconciliation, which required only 50 votes instead of the normal 60 votes, so one party could basically enact the bill. To partially pay for the bill, according to the CBO, the cuts to Medicaid will be about $9.1 billion to $1 trillion over 10 years, or more than 10%, and that's more than 10% of the total Medicaid budget in the country. So you're really talking about a major hit to these programs, both nationally and in Virginia. And it's projected that millions of people nationally will lose their Medicaid coverage during this period. And if you add the cuts to the Affordable Care Act, or what's commonly known as the exchange and SNAP, you're talking total cuts to all of these programs are of about $1.4 trillion over 10 years. In 10 to 15 minutes, I can't and don't want to bore you with hitting everything in these bills, but I'm going to try and deal with it at a high level and also explain what the impact of these is. First, the background of how Medicaid works. It's a joint federal-state program, and it's jointly funded by the federal government and the various states. Each state runs its own programs, and they differ significantly among states. The states have great flexibility in the services they provide and how much they pay their providers and who's eligible, as long as they meet minimum federal guidelines. In Virginia, the federal government matches payments to the state for covering Medicaid services at about 50% for the general Medicaid population, and Medicaid expansion for people whose income is between 100 and 138% of the federal poverty level, at 90% for people covered under that expansion. And the state makes up the difference. And when you're talking about who is an expansion beneficiary, these are folks, for an individual, somebody who makes between $15,650 a year up to $21,597 a year. And if you're talking, and for a family of four, $32,150 a year and $44,367 a year. So you're not making a whole heck of a lot of money to be on the expansion, but it has made a huge difference in basically filling the gap for people who are uninsured. It cut the uninsured rate in the United States dramatically. The program, Medicaid is now the largest insurance program in the country. It covers about 20% of the population. And in Virginia, we currently cover about 1.2 million people in the general Medicaid program and about another 605,000 people in the expansion. So approximately 1.85 million people are covered by Medicaid in Virginia. And when you have federal cuts at this level, there are basically three ways you can handle it if you're a state. First, you can raise taxes. Second, you can cut provider rates, which are generally already lower than private rates and even Medicare in most cases, or cut services and eligibility in the program. While you may hear arguments that have come from fraud and abuse and waste, there's virtually no provision in this act, that addresses that. When you're talking about fraud and abuse and waste, basically that's handled by the Inspector General's office, and very active, may I add, in the United States Department of Health and Human Services, the Justice Department, and FBI, which actually have Medicaid fraud units out in the country, and very active fraud units in the U.S. Attorney's offices. In each state, including Virginia, has what we call a Medicaid fraud control unit, or FUCU. And since Virginia uses private managed care plans that are paid at a fixed rate per member per month for the members they cover, and I believe they're limited to a 3% profit margin in Virginia, they have every incentive to closely monitor payments to providers and operate in an efficient manner. And Virginia has this year established also a Medicaid agency, a managed care fraud unit. So these cuts will go far deeper than fraud and abuse. Also, there's been on the media, you may hear a canard that this bill eliminates payments for illegal immigrants. Actually, Medicaid has always, the general statute, Medicaid has always eliminated patients for illegal immigrants. This doesn't do anything in that area. What it does do is a small group of legal immigrants with papers can get covered by Medicaid. And I'm talking about people, for example, like Afghan refugees who came here under American protection because they did things to people who basically supported our soldiers while they were over there and would be slaughtered by the Taliban. It's a very small group. Other than that, illegal and undocumented immigrants have never been covered under Medicaid, and this bill doesn't do anything in that area. So let's talk about the two of the big provisions in H.R. 1. H.R. 1 establishes work requirements on the Medicaid expansion population in states like Virginia that have adopted the expansion. Namely, again, recipients 19 through 64 must be working or participating in qualified community services activities for 80 hours per month. And there are certain exemptions, for example, parents with children 13 and under, medically frail individuals, and individuals with disabilities, and it's going to take effect in December 31st, 2026, right after the next congressional elections, because Congress wanted to avoid having it take effect before then. And it sounds reasonable with several exceptions. Historically, they don't work in healthcare. They add significant administrative costs. They generally hit the wrong people. It can work in cash benefit programs, but it has never worked well. It never worked in Medicaid programs in any of the states that have tried it. And according to the Kaiser Foundation analysis, 92% of Medicaid beneficiaries in the general population work. When you're talking about the expansion population, you're talking about people who are making 100 to 138% of the federal poverty limit. So those people are almost by definition working. And in the past, the two states that have implemented it in the past, it's been a resounding failure because they don't hit people who aren't working. The main reason that they failed is because they're so complex to administer that the people who really get caught in this, in most instances, are people who are actually working but can't work through the bureaucratic aspect of it all. Arkansas ended up knocking a significant number of people off the program who were working because of the problems in reporting and these folks were unable to report or didn't report. And in New Hampshire, Governor simply paused the program because of this fact. Currently, Georgia established a program that was sort of an expansion program with work requirements and had extremely poor results in that area. You have to do also, you're likely to depend on technology for implementing this program. And yet there are a number of areas throughout this country in Virginia that don't have internet. So you're generally cutting out the wrong people, i.e. people who are working and fail to report because of the complexity of doing so, and communication difficulties. And they're also going to increase state administrative expenses significantly in terms of staff time, systems, and adjustments, and likely including increasing the rates that they pay their managed care programs, because they're going to have to put in additional people and additional work. And the Congressional Budget Office again estimates that this provision alone will result in 5.2 million beneficiaries losing coverage during this period. And I've seen higher estimates under other estimates, but the CBO is a nonpartisan entity established by Congress. Also, from the perspective of the community overall, do you really want a lot of sick people walking in the community, infecting everyone else? HR 1 now I also want to tell you that the difficulty in this area, we just went through, Virginia's better than most states, but we just went through what's called the revalidation in Virginia, which means that because we had in COVID, the American Rescue Plan told the states you could get a 6.2 bump in your reimbursement rate, but you couldn't cut anybody off of Medicaid, even if they otherwise would no longer. Every state had 1 year to do a complete revalidation of every individual. This was a one-time event on Medicaid. In Virginia, I was on the board, for example, and we were talking early on about how do we get the word out to people that when you are asked, you have to look at this and respond. And we found out things like, for example, one of my colleagues on the board was medical director of a federally qualified health center for homeless folks in Richmond. And for those folks, the only way they're home was, in essence, that federally qualified health center. So if you tried to send messages to them elsewhere, they'd never get there. We didn't know that. And we started finding out all the things we didn't know. So there was an incredible effort in Virginia to go for outreach from numerous organizations, almost like a Dunkirk operation. We also had the plans out there notifying folks. We had the legal aid out there notifying folks. Churches, we went to the churches, we went to just a whole host of agencies and not-for-profits. And that was an enormous effort. And that was only for one time a year, this year. And Virginia did a great job. This is going to be an effort that you're going to need to do every single year. Actually, every month, every year, because people have to be reminded how to report. And it was an incredibly difficult effort just for that one reporting. And that was sort of the normal process for folks. Getting employers to understand how to get these reports in, getting people to understand that you have to do this every 6 months is an enormous undertaking, and that's why it didn't work, and why the people who were cut off in Arkansas were generally, not universally, but generally, a large number of folks who actually had jobs. And as I said, Governor Sununu in New Hampshire simply paused the program because of those problems. And the second major provision is HR 1, which places limits on provider taxes and what are referred to as state-directed payments. These payments are, these provider taxes are in essence a backhanded way for the states to create additional Medicaid revenues and have the feds pay for them. And while they may be viewed by some as trying to game the system, most states have now become, rightly or wrongly, heavily dependent on these revenues to provide adequate payment rates to providers and to provide adequate services. Basically how this works is that states will charge providers a tax. They'll then raise the payment rates for that tax, and the feds will then basically make providers in the state whole. It has been limited to 6% of revenues for any provider. Again, mostly the southern states heavily rely on these, Virginia less so. And Virginia uses these provider taxes to pay for the expansion, several optional services, and to increase provider rates for some services so that it can simply attract a reasonable number of providers who otherwise wouldn't participate in Medicaid, because the payment rates in Medicaid generally are lower than they are for private physicians and even for Medicare in many instances. So what does this provision do? Well, it says no new provider taxes for everyone, and no increases. And currently, as I said, the provider taxes are limited at 6%, and Virginia doesn't use them heavily. But it also, for states like Virginia that have expanded, and only for states that have expanded Medicaid in 2027 to 2032, they're going to start reducing that 6% cap down to 3.5% cap. They won't do that for the non-expansion states. And when we're talking about supplemental payments, states will for certain specific services, will pay additional payments to providers in order, in Virginia, for example, we had a substantial shortage of physicians and counselors who were willing to treat drug-dependent patients, often opioid abuse patients, because Medicaid simply paid too little. So we established a nationally known program as ARTS, referred to as ARTS, and that was and then by increasing provider rates, they were able to recruit many new docs and counselors to take Medicaid patients. They would not have otherwise done so. And there are a number of other provisions that are going to increase state workload and expense, and that are going to result in additional beneficiaries losing their coverage. But those are the two major ones. There are also a number of provisions that would either replace additional administrative requirements and expense on states and result in beneficiaries losing their insurance, such as requiring eligibility determinations every 6 months rather than yearly, requiring co-payments of $35 or more for part of the expansion population with incomes of over 100% of the federal policy for the poverty limit. And others would make it more difficult for people to apply or have retroactive eligibility or obtain services. Okay, so what are states likely to do to react to the loss of federal revenue? These types of cuts likely, as I said, would force states to consider cutting who's eligible or services from the program where they're permitted by federal law, cut provider rates, which are already generally below rates that they receive from other payers, or 3, increase state taxes to fill the gaps, or cut the services they cover. In terms of eligibility, it's a very complex calculation. The federal law generally requires states to cover low-income families with children and disabled and aging folks, generally at or below the federal policy limit level, which, as I said, is $15,650 for individuals and $32,150 for family of 4. However, there's no floor that the states have to cover, so they can lower income levels for qualification as they wish. And that, again, is going to increase the number of people who are uninsured. In terms of services, there are certain services like hospital, physician, and nursing home services that are required by states to be covered. But there are a number of other optional services, such as adult dental services, home and community-based services for disabled folks, eyeglasses, and other services. And depending how states choose to apply these cuts, they could eliminate optional services that they cover. And in terms of lowering rates to providers, as I mentioned, Medicaid rates are not as low as you can go in most states. And it's likely that cuts would reduce the number of non-institutional providers who would cover Medicaid beneficiaries. Now, institutional providers like hospitals and nursing homes, because of the dependency on Medicaid patients, are unlikely to drop out of the program, but not other providers. And as a former reimbursement lawyer, I like to refer to healthcare payments like a balloon. You squeeze one end and everything else balloons. So providers are likely to raise, who do participate, are likely to raise, demand higher payment rates, meaning insurers would have to pay more, meaning that private insurance rates would also go up. And also, when you're increasing the number of uninsured patients, you create folks with significant backups in the emergency rooms. It increases the amount of free care that they would need to provide, and especially rural hospitals that frequently are on the brink of bankruptcy anyway, are susceptible to this. And it's projected that this is going to result in even additional closures of these hospitals. And with the loss of coverage or cuts in covered services, again, many patients are likely to show up in the ER with significant illness. With respect to rural hospitals, Congress did create what's called a Rural Hospital Transformation Fund that provides about $50 billion to states over a 5-year period. Well, this is going to help. It is considered not nearly large enough to make up for the impact of the cuts, and in Virginia we've already seen several rural hospitals closing, and it's anticipated that you're going to see more rural hospitals closing as these cuts come into effect. And there's already a major shortage in the healthcare workforce, especially hospitals and nursing homes, and that's expected to be exacerbated because they're not going to have the revenues that they might need to raise rates for their employees. And just to put this in context, I was speaking off the record earlier this spring with 3 Medicaid directors, one from a blood-red state and 2 from purple states, 2 with Republican state legislatures, 1 with the Democratic legislatures, 2 with Republican governors, 1 with the Democratic governors. Off the record, these guys were all horrified at what was likely to happen. Whether you're a Democrat or Republican Medicaid director, these folks are professionals. They may approach how they do their jobs differently, but they're friends and they collaborate with each other. And as I say, these 3 Medicaid directors, and this was in confidence, were absolutely horrified at what Congress looked like it was about to do. Now let me talk about, very briefly, about the enhanced subsidies on the exchange. The enhanced subsidies that were enacted through the American Rescue Plan expire at the end of this year, so that if Congress doesn't extend the subsidies, people in the exchange will see their premiums increase exponentially, and for many, make their insurance unaffordable. And I've seen projections up to 200 to 300% increases for those folks on the exchange. And also there are other provisions in H.R. 1 that affect these applications, that affect application is such a short window of time within which you can apply any automatic renewal. So for anybody here on the exchange, be very careful. Even if you're keeping your old plan, make sure that you file a renewal. It's required each year, and delaying the time when subsidies start. So CBO, again, has found an additional 5.1 million beneficiaries will lose their coverage based on the expiration of the premium tax credits and what is referred to as the marketplace rule. And that's going to increase the number of uninsured patients and again, further stress out the hospital system, especially in rural hospitals. And the Virginia State Corporation Commission has projected that if these subsidies are not extended, these changes would result in about 100 to 200,000 people in Virginia losing coverage. And again, as I said, I want to address the canard on illegal immigrants that you may hear getting coverage if you take away these provisions in H.R. 1. Cheryl Roberts is the Medicaid director in Virginia, and she went out of her way again to stress at the most recent Virginia Medicaid board meeting that Medicaid law prohibits benefits to non-citizens, so repealing these cuts will not result in any payments for any or eligibility for any illegal immigrants. As I said, there is one small carve out for a certain group of citizens who are documented and are in the country legally, like the Afghan refugees, but it's a very small number of folks. And as Cheryl said, repealing these cuts will not result in a single individual illegal alien receiving Medicaid benefits. So, and finally, as I'm not an expert in the plan like Brad, in SNAP like Brad is, but I do want to mention that how important adequate nutrition is. In North Carolina, in addition to helping beneficiaries, in North Carolina, the Medicaid program established pilots that provided, among other things, healthy food to Medicaid beneficiaries. It was in several counties. And in addition to dramatically increasing the health of these beneficiaries, it actually saved the Medicaid program $85 per month, per member per month. That's a huge number. And unfortunately, it looks like that program won't be extended in large part because of the cuts and because of some changes that have been made at Hachey and Health and Human Services in the area. And not only that, the healthy food boxes that they were providing, I talked to the new secretary in North Carolina before, basically they help the economy because they use local farmers to produce the foods. That was a requirement. So anyway, I'm happy to take any questions that you might have.
Thank you, Michael.
Sure.
Very enlightening. All three of you have been very, very helpful. Before we get to questions, let's talk. Let me introduce Mary Eiserman very quickly here so she can tell you about this upcoming The Importance of Water program that we're going to have next week.
Thank you. Thank you all for everything you shared. It's really great to see folks coming together to learn about these things that are going to impact us. I've been glad to attend to 2 of these 3 forums. They've been very, very good. I have some questions. I won't keep you all too long. But I'm with Friends of Nelson, and we have kind of taken a couple years after the Atlantic Coast Pipeline was canceled and thought about what we want to do in Nelson and how we want to stay organized to be present for the next inevitable thing that we need to work together for. It's a time that obviously is important for people to come together. I think we can all agree on that, and that's the reason for these forums as well. So what we're doing is the second in our series of forums. The first was on electricity. The second will be next Wednesday evening on water. These are experts that we're going to have to come speak to you in our county about issues that are going to impact us. So one thing that stands out to me in thinking about water in our county, and I've worked with farmers and water for years, is a Region 2000 report from 2009 projects that the water supply in Nelson will reach a point where there is a shortage around 2058. This is when projected public water system demand will exceed the current capacity. So we need to be planning and thinking about this, where our water is coming from, how other things that are happening in our state are affecting this. Our county is required to have a new water system supply plan submitted by October of 2029. That process is just starting right now. So we have time to learn about these things, and as citizens to, vouch for what we think is important and how we're going to live in the future. So I hope you all can join us for this forum, and I hope we can all keep coming together and learning together. It's right here at 6 p.m. And I have extra flyers, and I can talk to you later too. So thank you all.
Okay. So who has a question for, right,
I have a question for the framework that you outlined for states, is that pretty much the same in the District of Columbia?
Yeah, it applies. It applies to states and territories. And the District of Columbia got hit with yet another, on top of this. In the last appropriations, the district was excluded for $1 billion that they've gotten every year from day one. So they're going to have an even bigger hit.
Question please, Brad. The third part of the slide indicated that the provisions for the increase in the age provisions for SNAP, moving from 54 to 64, and likewise at the other end also changing. When do they take effect? Is that now? Is that later in the?
I believe that's going to take place in 2028, or 2027.
This is all looking at 2028. I'm sorry, the impact this will be 2028.
Oh, the age?
Yes.
I'm not sure now that I think about that. I know the error rate takes place in 28. I think the age restrictions are going to take place. They're going to have to work them in because they have to come out a way of actually doing that. So there's going to take a little while to get that in. So it's probably a few months out. I don't know how far.
And then, Michael, the same question as relates to Medicaid. Are those new provisions coming in right away, or are they going to be later in the time?
It's staggered. The cuts on the Affordable Care Act are immediate if the subsidies aren't extended. The work requirements come in right after the elections. I think that was probably carefully calibrated without an understanding of what has to go in before that. An example in Virginia, we're going to need the new governor, whoever it is going to need a Dunkirk to first of all set up a system that can accommodate people from all over the state reporting, and their employers reporting every 6 months. Right now, all I can tell you is that Cheryl Roberts was telling me that I think it was either 250,000, I think it was a backlog of 250,000 revalidation applications because the social services folks have tremendous vacancies out there. They're not paying them a whole heck of a lot, and they have enormous vacancies, and that slows down the system tremendously. Also, just getting knowledge out there is just incredibly difficult, as we found out. We did it. The person who was in charge of this at DMS did just a magnificent job. I'm not sure that anybody did as good a job in the entire country, but it took enormous amount of staff time. You're going to have to do that time and time again to get people's focus. As I said, every state that's tried it has failed. In terms of the provider taxes, parts of it take place immediately, other parts take place in 2027 and out. So it's staggered, but some of it hits immediately after the congressional elections in 2026. And we're already seeing rural hospitals in Virginia closing. Yeah.
So, sorry about my voice. The shutdown, what the Democrats are doing right now, is your understanding that it's just the AC credits they're trying not to expire, or is there something else in Medicaid? This whole Medicaid issue?
The principal push, and it's both the Democrats and Republicans, the way this was set up. Johnson took the House out Wednesday. For the Democrats, they see this as their only leverage. I don't know how we want to call it, how we want to refer to it, but it's predominantly the Affordable Care and the extension of the tax credits, as I understand it. If I understand it, if the subsidies were agreed to,
we know the renewal period is coming right up. If Congress can get that back in, can we save the renewal process this year?
Yeah, if it's done fast.
It has to be done fast.
Yeah,
I know that's
open season is coming up,
Right.
which is one of the reasons that part, and also the only point of leverage. If they don't, this is the only place that Democratic votes are required. Just as the reconciliation was the only time that Republicans could pass something with only Republican votes. This is their only leverage. So that's why you see this occurring. And they want to spend. It's got to be done. It's got to be done very, very quickly. The insurance companies have to also figure out what are our rate increases going to be. Once you pass early November, it's going to create immeasurable chaos. It's already difficult. I can tell you from knowing how insurers operate and develop rates.
Well, they're already building in people leaving the plan, as part of the increase in the rates. So, we're going to unscramble that.
Well, the tax credits will be used to lower the rates themselves. So the plans can handle it. It's getting word out to subscribers. It's going to be difficult.
Gotcha.
Yeah. What are you going to, how much is this going to affect you as the person who's being insured? What are your costs going to be? Are they going to be $25, $100, $600, or $1,000 a month? And that's what they've got to get out before open season.
And I have a question for Brad. I walked in a little late, but did you talk about how the schools would be impacted by any changes to the SNAP program?
How will we impact?
The schools. So right now, they're directly certifying. Well, right now, Nelson County feeds all the students.
Right.
And they get, because they have a high enough percentage of free and reduced lunch, they think, because they haven't had to certify people for a while. So is USDA changing the formulas so that they don't get as much reimbursement?
No, I don't think there's anything in SNAP that impacts the formulas for the school systems, no.
I know they're not impacted this year, because whatever happens in USDA will impact them next year.
What I've read, I didn't see anything about the school systems at all.
That would be true.
Yeah.
Brad, do you have any idea of how much his projected projected to be saved for the federal government by these changes to SNAP? Like, how much money do they think they're going to save?
Well, the target is to reduce spending by $186 billion by 2034. I don't know how they're going to do that. That's what's been put out.
You had a question, Pat?
Impairment. With the budget cuts and with, what's the probability that you'll get the funding on the grant, or is that a separate entity that you automatically have? You talked about earlier that you're going to get some grants for some new programs.
So right now the program is because of that Centera Cares grant. We've got another year of funding left to that initial grant. We've just applied for another grant for 2 more years. We haven't heard about the results of that yet. It looks like this is probably a really good idea for the county. So in the absence of any further funding, the plan is to go to the county to have the county fund continuing the program. But we don't rely on any federal funds or, for that matter, state funds.
And if you're looking at what providers, what insurers are likely to do, or what Centera is likely to do, the push will be to explain that by having you out there, you lower their inpatient hospital costs. And I shouldn't say and because I know I'm on a board that works with colleges and universities to help place foster youth to go through higher education, and we're losing a number of academies because the universities themselves are being squeezed with the loss of federal funds. So whether Centera feels that or not, I think you're going to have to make the pitch to Centera you're saving them money.
And in larger systems where the healthcare systems have shown that it's costing the hospitals a whole lot less money to keep people out of their emergency rooms, particularly those who don't have the resources to pay. So keeping your community healthy represents a decent cost savings. And one of the strategies we have is to go to the systems with larger pockets like UVA, to say, would you like to chip in? But right now we are running reasonably well with under the current grant. So these are all contingency plans, should that go away.
If you had come to the end of your grant and the next step is to get county funding for that. This county has a little bit of history, and we had a school nursing program for Nelson County schools that was grant supported. Started out with the Virginia Department of Education and Virginia Department of Health collaboration, and they offered a grant out, and we got the school nursing program started for Nelson County schools. And then we went to a rural health outreach program grant through the feds, and then when that ended, so we're talking about like 6 years later, that school nursing program was completely entrenched in the schools and had a tremendous amount of public support, and was making a huge difference with the health of the students, especially immunization rates. So we filled the Board of Supervisors room with teachers and parents and healthcare providers, and everybody talked to their individual Board of supervisor, and so they amazingly supported it and fully, so we were very, very lucky. But I think it takes a lot of individual work with the supervisors. It's a different world now than it was back then. But I think that this county might just come forward if we do it the right way.
The big ticket items have already been paid for. So now it's primarily just staffing. looking at the overall county budget, it's almost within a margin of error. So we're talking 1.5 FTEs to staff the program. So it won't be a big ask if we have to ask.
One more question about you guys thinking about the SNAP and health in general and costs moving forward in the future. Do we have other tools, other resources, other funding sources available to promote healthy nutrition for the general population, especially those that have a harder time getting it? Are there other tools than SNAP available?
The one I mentioned was actually not a SNAP program, the Standing Food Nutrition Education Program. That was actually a NIFA-funded program through extension, and that's gone now. The other ones, in general, we put out a lot of different grants for different types of things. And we do food safety, we do nutrition. And I can't speak to all of them. There's like 40 different funded lines in NIFA. And most of it is competitive grant programs. It doesn't assure anyone getting it because they're competitive grants. The reality is, there's so many potential applicants that the typical success rate is about 10% on our granting programs. So that means you've got a lot of really good grants out there that aren't getting funded. And it also, what it does is actually enforces and requires us to have integrity and quality in our grant review process. Because when you're saying yes one time to every time you're saying no, you remember the congressman, and we have to respond. So that's been one of the things I hated in one way, but another way I liked it, because I always knew we operate with a high level of integrity and quality in our grant reviews. And Congress always had to follow up with the person asking the question, and they always knew they're going to get a good answer for this.
And there are two other ways that you might think of. In Medicaid, again, in North Carolina, they actually provided healthy food as part of funding social determinants in the pilots. And by the way, at the time that this was done, you had a Democratic governor and a Republican legislature, and the secretary actually was Mindy Cohen, who headed the CDC later on, and as I say, they showed tremendous savings. And you may also be able to, in Virginia, consider the managed care plans. Some of them provided address the social determinants. So with these figures, I still think it's going to be worth trying to see how much of the gap they might be willing to pick up in the future. And now it does take some upfront investment, but there's a real savings on the back end.
I just wondered, the two of you want to address or talk about, Blue Ridge Medical Center has a current program, federally funded grant for food pharmacy. You have to be a patient at Blue Ridge, and you have to have hypertension or diabetes, and we have counselors that are working with patients to introduce healthy foods, and we've had huge success with our patients. So if anybody would like to participate in it, we need participants too. So that is one program in the county.
What is the name of that one again?
It's at Blue Ridge Medical Center. It's called the Food Pharmacy.
Thank you.
And there's several, that wasn't unique in the United States. There were several programs that provide food prescriptions out there.
I should probably add to that, about 45% of the funding through NIFA, or that $2 billion, actually goes out as capacity building funds to the land grant universities. So Virginia State, they get a fairly good share of that. Virginia State and Virginia Tech, they get funding from that, and they can collectively make decisions on how they want to approach the topics of the highest concern and highest interest.
And meanwhile, there's a lot of pressure on the local volunteer efforts to provide food. So we have the food pantry at St. Mary's at the northern end of the county, and then down 29, there's a big one at Heritage Center, and then a lot of the churches are doing amazing work with food boxes and feeding programs. Unity and Community does a lot of work. So, but the pressure is really on those volunteer programs in our county. The participation in those is through the roof already. So when we lose this, it's going to be very hard for us to keep up with.